Just by way of introduction for any members of the public and fellow governors, is we had an interesting workshop session this morning, a very good discussion around the paediatric services offered by the hospital, and a good patient story around it too. A very enlightening presentation and discussion around the volunteer services, which was very impressive indeed, and a business as usual discussion around finances to make sure that we're delivering the best value for the NHS pound we possibly can. And that was a very good conversation too. So with some further ado, I should say that Gertie Nick Phillip can't be with us this afternoon. Unfortunately, to be called away on other important business. But this would have been Gertie's last board meeting, so it would be wrong to go without thanking Gertie for her hard work and efforts on behalf of the Trust, and wishing her luck in her new role, and a good career move for her, and particularly important since he moves her back closer to home and nearer to her family, which is great. So good luck to Gertie. And with that, then we'll move into the main board. So in terms of apologies for absence, we have apologies from Russell Hardy, Chairman, and Glenn Burley, the Chief Executive. So I'm deputising as Chair for Russell today, and Adam for Glenn. Bhaskar sends his apologies, as does Paramjit and Sue Whelan-Tracy and Phil Gilbert. There are no other apologies, Sarah, that I've missed.
Just Gertie's and Nick's deputising for Gertie today.
Thank you, Sarah. That's great. Any declarations of interest? Ollie, should I say?
Yeah, I've been appointed to Head of Fundraising and Partnerships for St Andrew's Healthcare, which is a charity that is primarily commissioned by NHS England, but also commissioned by some mental health provider trusts.
Congratulations. Okay, so item 3 is the minutes of the meeting held on the 5th of June. So is everybody happy that the minutes are a fair and accurate reflection of the discussions that took place? Please raise your hand if you're not. Okay, thank you. And item 4 is the minutes of the extraordinary board meeting held on the 19th of June. The same. Is everybody happy that the minutes are a fair and accurate reflection of the discussion? Okay, super. So now I've got to catch up with myself. Just bear with me a minute. Actions page 23. Too busy talking to keep pace with the notes. So that moves us on to the actions update. So there are 2 actions complete. No, there's 1 action complete. No, 2 actions complete and no actions outstanding. So if everybody's happy that that's correct, we can move on to the next item. And the next item is a recommendation for senior independent and change to non-executive director voting rights. So the paper here proposes, I think this is me, Sarah, to do this, proposes that should Sue Whelan-Tracy leave the trust when her term finishes, that Phil Gilbert, who is currently an associate non-executive director, should take on the role of senior independent director, and at the same time be given voting rights in accordance with the trust constitution. So does anybody have an observation or object to that proposal? Please raise your hand if you object, otherwise we will pass that through. Okay, that's given. Thank you very much. And that then, Adam, moves us on to the Chief Executive's report, please.
Thank you very much, Simon. So a reasonably short Chief Executive's report this time. The first section of the report, Glenn outlines his changes to the NHS financial regime nationally, and in particular notes that the first submission of the plan by Systems resulted in an aggregate deficit of over 3 billion, the highest it's been in the NHS. As a result, NHSE have met with systems and regions to try and drive further improvements to that financial position, and those conversations are still ongoing. Glenn shares his really helpful insights actually on the current regime and the impact it has had on organisations like ours. Notably, I think there's a concern around intervention on a system basis rather than a trust basis. What that might mean is organisations like ours that rank well in productivity and predict a break even may still be penalised with actions such as capital reduction, and those conversations are still very live. But I think it's important that that we are aware of potential impact of the position nationally. The report moves on to consider urgent and emergency care services and their interaction with the financial regime. So we will talk later on in the board today about the considerable and sustained demand we're seeing over and above what others regionally are seeing at the front door. Previous financial regimes took account of that in tariff, and obviously the current block contract situation doesn't, and that does undoubtedly impact us. There is a debate about whether that also impacts delivery of the 4-hour standard nationally. We know that 4-hour waits in ED are really important in terms of quality and safety, and certainly that's an area we continue to drive. Having said that, tariffs based just on activity and performance are not enough and can lead to some disincentives. Glenn has been advocating for a more hybrid approach that includes, for example, best practice pathways where same-day emergency care and community services are considered. And certainly in SWFT, we've done some really great work on looking at how we use SDEX and community services to manage that demand. I think we have to remember that going forward, flow is our ability to move patients out of our emergency department and through hospitals ultimately to discharge, is really complex and involves multiple agencies. And I think that's why some of the conversations around tariff and financial regime are really important. And no doubt we will hear more about those approaches in future financial plans, but I think it's important to note the impact on us in the current pressure situation we're in. The report also notes the work on the pathology network. So members of the public and board members may remember Lord Carter's plan quite a number of years ago to develop networks of pathology service. I think it's fair to say there's frustration nationally that this hasn't moved quickly enough when it's probably more important than ever in terms, again, of the demand pressures the NHS is seeing, and with the progress of technology making things like virtual network easier. We clearly already in a pathology network in Coventry and Warwickshire with other providers, and there is a plan to increase that network to include Hereford and Worcester, and those discussions are very live. It is not a small undertaking, though. It is a significant challenge involving systems and different ways of working and so forth for pathology service. And that model is being discussed currently in more detail, and there'll be a detailed discussion at our Foundation Group Strategy Committee next week, because clearly that involves all 4 trusts that are part of the Foundation Group. Finally, the report covers more from our great teams and celebrates the site office this time. So the site office is pretty much the brains of the hospital. It works to support flow, to manage patients outside of ED, and movements around the hospital. Clearly, that's been even more challenging since COVID as we manage more infection control issues, and as we see the demand we are currently seeing, the work of the site office is more important than ever, and they do a fantastic job in some really tough circumstances. So I'd like to commend that team and the work they do to the board. The report ends as usual with the monthly list of board to ward visits that board members have undertaken. I think that's all I've got today, but I'm happy to take any questions.
Adam, thank you very much. So any observations or questions for Adam around the CEO's report? Okay, thank you. Well, then within the performance and review section, then that moves us on still to Adam, to the integrated performance report. So Adam, your MD's report then, please.
Thank you. Yes, and I'll give a bit of a summary before handing over to colleagues. So I think it's really important to note, as I said, the really continued high levels of demand we're seeing across our services, in particular, the impact that that's had on our emergency care pathways. Clearly, the report covers last month, but I think I have to mention the last week, which is probably our longest period of sustained pressure in our services. We've been at level 4, which is the highest escalation level for longer than we've been before, and that really is a picture we've seen ongoing for the last few months. The Chief Operating Officer's report has more detail on this, and no doubt Hakamal will comment on that. The impact we've seen on, for example, out of area activity and shifts on activity within the Coventry and Warwickshire system have had a really profound impact on us. Despite that, I've been reassured that we are keeping a real focus on the quality of our services at the fore. And as an example of that, we've seen a really positive reduction in our falls rates on wards, with numbers now at their lowest ever. We've also seen improvements against the diagnostic standards, which I think, given the sustained increase in numbers of 2-week referral numbers, has been a real achievement, and I think really shows the work we do as an organisation to make sure our patients and the quality of our services is really at the front and balanced with performance that we manage day in, day out. In terms of our areas of focus, cancer targets remain a challenge, and I think we had some really difficult months in April and May. We are beginning to see some improvements and are working with system partners on models and ways of working to support this. That's all I want to say in summary today, but I will hand over to my colleagues, and I think Fiona and Charles are first.
Adam, thank you very much. So Fiona and Charles.
Yeah, thank you. So I'll start with just a summary. So as Adam said, it is really reassuring that despite all the demand that we're under, our quality indicators remain good generally. Our falls rate particularly, and those falls with harm, our maternity indicators all remain good, other than the demand and the conversion to C-sections. Low levels of complaint, good FFT, friends and family test response rates ranging from sort of 83 to 94% of our patients recommending us as a place to receive care. So all pretty good despite the pressure. The areas, I suppose, of focus for the coming weeks is to keep on top of our infection prevention. We've seen a slight increase in our C. diff rates, and we are analysing these as to whether there is a trend between them, and early indications suggest not. There are a couple that were a couple of patients that were nursed in the same bay, so we just almost as a precaution, really, we've done a deep clean and fog in there, and we're putting some scrutiny onto our cleaning standards as a result. It is difficult to clean hospitals when they're so busy, so we do need to keep vigilant on that and make sure the standards are maintained. And the other one, as I've mentioned in my report, there's been an error in the pulling through of friends and family relating to maternity and community, so we're just unpicking that. But I don't expect that to show anything different to the A&E and acute figures that remain good. Happy to take questions.
Fiona, thank you very much. Charles, do you want to add anything before we go to observation?
Unless you want to do mortality at this point, which is a little bit later in the performance report, and that shows stable mortality indicators which are within control limits, and the latest shimmy that's come through shows a slight fall, which is promising. We continue to probe in to see whether there are any areas where we can improve quality, or there are any preventable deaths. But otherwise, I just concur with what Fiona said, that the pressure on the trust and the amount of work we're doing is remarkable, and the fact that all the indicators suggest we're maintaining quality, I think is a real testament to the engagement of the staff and everything they do every day.
Yeah, very well said, Charles. So any observations or questions for Fiona and Charles? Okay, thank you very much. So that then moves us on to Harkamel to talk about operations.
Thank you. Sorry for repeating what's been said, but I think I should go first so that people don't steal my thunder. As has been said, May was our busiest month ever for A&E attendances, and I think if you watch back in previous boards, you've probably heard me say how busy we've been. So it is quite surreal, I think, to pass a milestone like that. We didn't hit the 78% standard, but against the backdrop of our busiest ever month, we still managed to hit 72.4%. And I'm really proud of that. I think that it demonstrates that we are still striving to achieve our standards, and we are going in the right direction against the backdrop of considerable pressure. And I'm really grateful to all of our SWFT teams for helping manage that. I talk in the report about how vital same-day emergency care is to that. But there's also the work that our wards do in terms of pulling these patients through ED, in terms of keeping these patients safe. And while they're waiting longer than we would want, we know that they're fed and watered and on the right mattresses and are having regular observations, which is really important. And out of hospital, the UCR performance was consistent, and having that those high levels of same-day response, it's the sum of the parts that keeps the organisation moving. And I think just at this point, I'd like to pass on my thanks to everybody. I have talked previously around the ambulance conveyancing, and between Fiona and myself, there's an action around putting more information relating to ICing in there, intelligent conveyancing. So I have put a section in the report. I won't always do it as detailed as that, because I'm conscious how big the board pack is. But I thought for the first time I share data like that, it would be helpful to have a bit of an explanation and to have some of that information in here. So essentially, when the West Midlands Ambulance Service is very busy and trusts are struggling to offload their ambulances, they enact something called intelligent conveyancing, ICing. And that's essentially where if Hospital X is busy, they'll send that ambulance to somewhere else in the hope that that ambulance will be offloaded. And then they can go, the ambulance can then go back out and respond to emergencies out in the community. So absolutely understand why it happens. That said, for us at SWFT, we are the recipient of a lot of intelligent conveyances, and it reflects how well we offload. It's not in my pack, but we were one of 2 hospitals in the whole of the Midlands region that maintained really excellent offloading times across the last year. So our average offload time is 20 minutes, and we know that often, it's average, often we're much quicker than that. At times we do have pressure, but we remain one of the best performing in terms of offloading. And the graphs in my paper will show the volume of ICing, and you'll see just how significant that increase has been. I've talked before about the risk of some of this, and just to reiterate, when we get patients from out of area that are hard to repatriate, it is because it's harder to discharge patients, they end up waiting longer, their length of stay is higher. And we've talked before around the increased risk to patients when they're in beds for longer than they need to be. On a human level, it's really hard for people to get visitors if they live really far away. So it just doesn't feel to me to be the most compassionate way all the time. So there's something about balancing all of those pressures, isn't there, within the round, but I've included that. And May was a record. We had 161 intelligent conveyances. That's 130% higher than last May. So when we talk about what some of these increases are, I think the percentage kind of puts it into context of like that's a staggering amount. Moving on from that, electives, big well done to the elective team. We had 113% of activity recorded when you compare ourselves to 1920. Despite phenomenal amounts of volume coming in through A&E, we didn't cancel any electives because of bed-related pressures. We retain the ability to say that. I think that's really important. And we managed to treat 63.1% of our patients within 18 weeks. And whilst that is a long way off where we used to be, we are in the top some of the top cohort of trusts within England to be treating our patients in that time. We do have some way to go. As I've said before, orthodontics remains an area of pressure, and we maintain focus on that, although those rates are coming down. Diagnostics, really proud that we've managed to turn a bit of a corner on diagnostics. There's still somewhere to go, but it was our best performance since March 2023. Cancer is less positive, and it's really upsetting to say that for the 28-day standard and the 62-day standard, that was our lowest performance since points last year. I've included in the paperwork just a graph of our 2-week wait referrals, and I think you'll be able to see that the referrals to along the cancer pathway remain exceptionally high. We are an outlier in terms of how high our increase has been and how it is sustained to be so high. Our conversion rate is dropping off, but those patients still do need to be seen and go through a diagnostic pathway. May does look like it will improve, and we are on track to improve. We've got lots of action plans in place and work with system colleagues. Finally, we had a very busy month for babies, and we had 302 births at SWFT in May. My focus slide this month includes an update on allied health professionals. I don't think I've ever done this before, and it just felt like an opportune time to remind board and to thank our allied health professionals and all the work that they do. So I've included some information of the work that they do for us. It's obvious, and they're a key part of our workforce and really enable flow and patient safety. And within the focus slide, I've got some examples of innovation, for example, using chatbots, our participation in research, lots of examples of prevention, and our role in senior leadership positions nationally. And that's it from me. Thank you.
Okay, thank you, Harkema. Harkema, can I ask you, you talked about the West Midlands Ambulance Service and intelligence and conveying, and I know we've been talking to them to try and get this system to work as well as it can for the patients affected and for ourselves. And I just wondered, are we making any progress in improving the service? Or
well, I think it's really difficult in terms of progress, because I think that progress means different things for different people. From a WMAS perspective, offloading obviously remains a key area for them, and we understand that. We have had a system review meeting with West Midlands Ambulance Service, with us at SWFT, UHCW and George Eliot, as well as system colleagues, which I think was really helpful. So we're really able to share some of our perspectives and offer some support in terms of expanding our call before convey to try and keep patients in their own home as far as possible. So those conversations are ongoing. I think it's more a symptom of just how busy the entire NHS system is.
Okay. All right, thank you for that. Any questions and observations for Harkema before we move on? No? Okay, so we'll move on then to what used to be called HR and is now called our workforce. So, Nick, I'm old enough to remember HR, you see.
Thanks, Simon. Yeah, me too. I'll take the report as read, and overall it's a positive picture for the workforce KPIs, including turnover, mandatory training, vacancy rates, and the recruitment KPIs, with more starters than leavers, as has been historically. And this is sort of supported with some of the work we've done around reducing time to hire. So there's a graph in the pack that sort of shows the improvements we've made over the last 12 months. Turnover also remains below target, demonstrating the work we've done around retention and ensuring good experience for staff. In terms of elements to highlight up, we have the new learning management system, which is rolling out across the trust from the 10th of July, starting with staff to mandatory training. And this will make it a lot more straightforward for staff to sort of access their learning and check their compliance, and also for managers to do the same. Moves away from the ESR interface to a much more sort of streamlined and intuitive interface to access that. And that managers will also have the ability to do a sort of decentralized report and check in real time, which they don't at the moment. After mandatory training elements rolled out, it will then be sort of the appraisal element of the system, followed by job specific training. So that will all be sort of implemented over the next couple of months. In terms of an area of focus, our sickness absence rate remains above target, but has reduced from last month. And is sort of higher than it was last year for the 12 months. What we're seeing is a reduction in short-term sickness absence, as we would expect at this time of the year in terms of seasonal absence, but a sort of an increase in the long term. As colleagues have mentioned, obviously this comes at a time of a sort of very busy operational period, so it's not comparing like with like. In terms of the absences, in terms of trends, what we've seen is sort of an increase in mental health related absence has been the largest single reason. That's not unique to us, and sort of that's the trend across the ICS and the wider NHS as well. So it's just something we're aware of, and have done deep dives into these areas just to sort of see if there are any underlying trends, but it is sort of across the board. In terms of actions around this, I'm in the process of reviewing our absence management processes alongside staff side colleagues to sort of augment that process both for staff and managers in terms of when they're going through, with a particular focus on increasing the support around long-term absences, which is sort of absent from the current process. This ties in with work we're doing across the ICS. So there's a sort of regional working group which meets monthly, so we can sort of take best practice that's been adopted elsewhere, incorporate into our policies, and make sure that we've got the best offer and we're supporting staff as much as possible, whilst also, you know, doing what we need to do to reduce absences across the trust.
Okay, Nick, thanks very much indeed. So any observations or questions for Nick? Ollie.
Yeah, hi, thanks, Nick. Just a quick question. In terms of appraisal, the corporate division seems to regularly fall behind. And just from an external point of view, I would say you'd assume slightly more flexibility of timing. So just wondered if there's any actions to try and invigorate that a bit more.
Yes, no, very good point, and it's sort of a trend that has been noticed. So with the implementation of My Learning, which is coming very soon, obviously that will make recording a lot more simpler. So what we've found is the feedback we're getting for corporate is the discussions and appraisals are happening. What they've been struggling with is transacting that on the system, really, in terms of actually that being reflected in ESR. Certainly it's not as intuitive as you might expect to record an appraisal. Within My Learning, it's 3 or 4 clicks, you know, date, time, completed. So that will also allow us, one, that sort of takes away that reason for being difficult to put it in, also allows a lot more tracking from our perspective, and certainly from individuals and from managers. So we're hoping that will increase with the transfer to the new system. We can really drive that through. So yeah, definitely a point we've noted and one that we're picking up.
Okay, thank you, Nick. Thank you, Ollie. Any more questions or observations? No. Okay, so let's move on to finance, soon to be called our money, I think, Kim, is it? In the same vein. So over to you.
Thank you, Chair. So just to remind everybody, SWFT submitted a break-even plan for the year in the context of a deficit plan of £27 million. I think Glenn's report, alludes to the fact that there is a requirement to get to a revised financial system envelope, and discussions, I think it's fair to say, are still ongoing. So there was pushed back to see if we can stick to the £27 million as a system, but that plan has been rejected by NHSE. So on that basis, conversations are still being had around our system plan. So we're working that through at the moment in terms of how that potentially might impact on our financial plan that we've submitted. But obviously we will keep the board informed as those discussions progress. But in terms of the break-even plan, we've actually profiled our break-even plan on a straight line basis, so effectively expecting a break-even decision month on month. Whereas the reality is that the delivery really of the cost improvement programme is more realistically should be phased towards the back end. By doing it this way, it gives us early oversight of problem areas or challenges so that we can get early grip really of our financial position to ensure that we do hit our financial plan by the end of the financial year. We do have some plans that are weighted towards the end of the middle of the year and towards the middle and end of the financial year. So I do expect the position to start to look better as that progresses. I think in terms of the CRP plans, we've got a finance focus session on our Excel and everything, and although the papers refer to some lower figures, the finance focus session is around making sure that all of the schemes that we've identified have got some financial targets that are linked to that. So that's what the team have been working on over the last couple of weeks. The other benefit really of being in a foundation group is that we have more recently been sharing each of our cost improvement programmes with other members of the foundation group, and we will bring that and share that with our divisions as well, to see whether or not there are things that other organisations have thought of that we've not looked at. So I think that's a further bit of opportunity. And I obviously took the board through a workshop session last month around productivity, and productivity is obviously really key measurement and something that we need to monitor as we progress, because there's a lot of oversight on productivity improvement moving forward. We are constantly obviously reviewing our financial controls in the context of the financial environment that we're in, and we will continue to do that, but also maintaining really that devolved accountability that we very much believe in this organisation. So we're just working in partnership obviously with our workforce team around any further controls around our staff controls. And other things. Agency, we've made really good progress on agency, you know, and that attests to the good work led by Ellie Ward and Jack Foster last year, and we continue to see that run rate really improvement. I'm expecting that to improve even further with the fact that we are nationally been mandated to cease any the use of off-framework agencies. Also expecting it to improve as we progress some cases around putting in some substantive staff as well to reduce the premium expenditure in some specific areas. I think that's all I wanted to say. We obviously are working around identifying really some of the cost pressures associated with the additional capacity challenges that we're facing at the moment, and operational pressures. So there is a piece of work around understanding really the drivers and the shift really, I think, in terms of the activity within our local area, so that we can take those further into negotiations for our position moving forward. Happy to take questions.
Kim, thank you very much. So just for the avoidance of doubt then, Kim, that in an environment where demand is very high, that we are still striving to keep costs very firmly under control and deliver value for money, and remain confident that we should be in a break-even position by the end of the year.
So that's withstanding all of those external pressures, we're doing the best that we possibly can in a very, very difficult environment. But they are risks, and I think it's appropriate to flag those to the board.
It is, but it's also important to demonstrate the striving nature of what we're doing to make sure we get where we need to be. So any questions and observations for Kim, please? Okay, thank you very much. So we've already covered the learning from death section. Charles covered that earlier on. So that moves us on then, Sophie, I think, to capital expenditure programme. Thank you.
Thank you. So just a couple of things to flag to board today. I'm flagging a slight risk around the amount of capital that is unallocated at this point in the year. We would normally have allocated everything, but board will remember we were sort of waiting for the confirmation of the 4 million, and also there was a number of other moving parts of the capital programme, which now means we're much clearer about how much we've got unallocated. Capital Committee have done a piece of work to look at how we allocate that now to some of our priorities, and there's about half of that that's going in a couple of weeks for approval, and a wider discussion and debate that will come back around some of the larger schemes which you've heard here before around maternity theatre, but also HSDU, so some of those really like key risks we're trying to manage with the programme. So it's just to flag that, but give you the assurance a number of us are working in the background to make sure we're allocating that appropriately and to mitigate that position.
In terms of capital, Sophie, that's not a risk. That just means we've got to allocate it effectively.
We've got to allocate it, and we need to do that quickly so we can deliver, I guess.
Okay.
Yeah, deliver in year. So in terms of the capital programme, it's progressing well. It's challenging. Costs are challenging on projects now, so we're having to do quite a lot and spend quite a lot of time as a team just really challenging every single, which we did before, but there's a much greater need now around the value engineering that we're doing, so we're cracking on with that. And I just wanted to sort of bring out a thank you that I've put in my report, which is the sustainability projects are so key to delivering our strategy as an organisation. They're really large scale programs across our trust. But the thing that has challenged us the most is changing our windows, and it has taken the whole operational and clinical team support with Chris's leadership to make that happen. So it's a big thank you to everyone really on that, and I'm happy to take any questions.
Sophie, thank you very much. Any questions or observations for Sophie? Adam?
Yeah, thank you, Sophie, and thanks for your leadership of the programme. It's been another really busy year, hasn't it? And you and your teams have managed that well. I just want to reiterate the point about the allocations and the fact we will have to make some difficult decisions, I think, in the coming months, because we have a number of major schemes which relate to risks on our risk register, and probably not enough money to do them all. So as Sophie alluded to, that prioritisation work has been going on and will result in a decision at management board and ultimately at board, but it will mean that we can't do everything we'd like to or want to this year.
Okay, point made, Adam. Thank you very much. Okay, so let's move on then to Excel and everything. So I think we're with you, Adam, on that one.
Yes, thank you very much. And I will take the report as read, but just to reiterate a few of the key points. As a reminder to members of the public, we set up our Excel in Everything programme last year, which was a different way of delivering our cost and productivity improvement programmes, recognising that the best way of doing that was balancing the needs and demands of quality, performance and efficiency. And we took that holistic review rather than just looking at financial savings on their own. That builds on our culture of improvement and really sets up a programme where ideas are coming up from the ground in the organisation. I think as a result, it went very well last year. And we've certainly seen that momentum continue into this year with a bit of a refresh of our work streams, which are highlighted in the report, and a large number of objectives and projects associated with them. We have this year, more so than last year, tried to align that with our strategy and big moves, and you can see that as part of the work streams detailed. Most schemes now have detailed finances. There remains some gap in the CPIP programme as we cost schemes in detail and look for other opportunities. I think the number just over the last few weeks has increased slightly from that in the report, so that's good news. The report itself also particularly highlights work in our children and young people's work stream and our digitalisation work streams, and I won't go through the details of that. Just to preempt a question, Phil Gilbert, who is not here today, asked a question about whether we're pushing ourselves hard enough on this. And I think that's a very fair question, actually. I do think there's more that we could do. And one of the routes we're taking, as Kim referenced earlier, was looking at other trusts in the group and wider to understand what their savings schemes are and whether we can take things from them. We're also working with the group financial advisor, and he has been involved in some significant savings projects elsewhere in the country. So we're getting him to do a bit of a sense check of our CPIP and Excel and Everything programme, just to understand whether there's more we can do. Phil also asked if we're driving digital hard enough to let tech and data take the strain more. And I'll come on to the Digital Health Board report in a moment, but I think no, we haven't actually. I think there is more we could do here, and one of the big areas that we are working with our Innovate colleagues to deliver this year is automation, and I think certainly in terms of saving staff's time and allowing them time to care and do the day job, that is going to be a big priority for the year. So I will leave it there, but I'm happy to take any questions.
Okay, Adam, thank you very much. I'll just get the cat off my desk right there with me. So any questions or observations for Adam? Oliver.
Thank you. Yeah, thanks, Adam, and that's really clear. And you know, I think it's great that you're reaching out and talking to people around other things the NHS are doing. I just wonder whether there's any opportunity to look at outside the NHS, you know, specifically around, you know, private commercial companies who have really gone on a digital journey. because we look quite understandably, we look quite internally sometimes, but if we engage with some, maybe through the university, we engage with some other companies, there might be different ways of looking at things that might be helpful.
I think that's a really good point, Oliver. We do a bit of this in our relationships through the digital hub, but I do think there's more we could do. And I think mining the knowledge of our NEDs would be a great place to start with that. So perhaps we can have a conversation offline about that.
Okay, Adam, I mean, I do think it's a good point. I mean, already, Adam, I've shared this with you, that the Royal Orthopaedic have a relationship with JLR, who are helping them to apply lean processes in the organisation. And I think, not to say we should be doing that, but it's a good illustration of looking for different sources of information and thinking that, and exactly your point, we should do more of that. So moving on then, I think we're still with you, Adam, then on the Digital Health Board and EPR.
Sorry, Simon, Yasmin's hands up.
Oh, sorry, I beg your pardon. Yasmin, I missed you, I beg your pardon.
Thank you. My question is similar to the previous question, but around carbon reduction and sustainability. And I note that we're talking about printing and postage and other things, but there's a whole vast other areas available where we can make significant reduction in carbon and improve our sustainability plans. Going back to the previous question, my question is similar, where I'm asking, how are we learning from industry where people are taking huge strides in reducing carbon footprint?
Yeah, that's a really good question. I might ask Sophie to answer that if that's okay, Sophie.
Yeah, thank you. So as a trust, we have our green plan with the 10 areas that we're trying to reduce carbon on, and it came back to board, I think either last month or the month before, about the progress, and there was about 8 areas we've still got risk on delivery. This year we're going to be developing the new green plan, so I think it's an absolute fair challenge. What I would say is our non-exec Phil Gilbert, who works in industry, does give us quite a lot of challenge on our delivery and brings some of that knowledge in, which is brilliant that we're sort of in that place. And Chris herself has a lot of, our lead for sustainability, has a lot of networks outside of the NHS. So I think we're really fortunate. We've got some really great people driving that. But I think when that comes to board, that'll be a chance for all of us to have a think about, actually, do you think we're going far enough, or what else we could do? But I know he's not here, but Phil definitely challenges and brings some of that industry into our plans, which is great.
Sophie, thank you very much. Okay, so shall we then move on and, sticking with you, Adam, talk about Digital Health Board and EPR?
Thank you. Yes, and again, I'll take the report as read. There is some great work going on across our digital teams, led by Innovate. Just want to highlight in particular the work we've done with Myton Hospice, who we've now supported both financially and in terms of implementation to have the EMIS EPR system, which is great news because we've now got EMIS in use across primary care, community services, and all the hospices in Warwickshire, which clearly has benefits in terms of the flow of information. Great news. We're also doing some work to replace the patient record system in our ophthalmology service. It's great also to see the work that's been going on in our digital hub, which has included some really innovative initiatives, including implementing a chatbot for triage in our wheelchair services. And we heard at Management Board last week about a augmented reality research program for training and learning in surgical services. So we're really seeing some good work there. The bulk of our work is clearly focused on a new EPR system, and we hope to sign the contract for that imminently. I think I also need to congratulate UHCW, who went live with their EPR a few weeks ago, and clearly that is the system we will be moving on to in due course. So it's great that they are now live and their implementation has gone smoothly, and we've had quite a number of staff from the trust and from Innovate over at UHCW to help them with their go live and to gain the benefits of learning for when our time comes. We will really see work start to ramp up on our EPR programme, with boots on the ground starting in the autumn, around October, November time, and clearly that will be a big focus of our work for 12 or 18 months following.
Okay, Adam, thank you very much. And it's fair to say, isn't it, that our level of confidence in EPR has risen as a consequence of the performance of UHCW in implementation?
Absolutely, yes.
Yeah, super. Thank you. Any questions or observations to Adam around digital and EPR? Okay, so pressing on then, we are on to the joint audit and clinical governance assurance statement, which is between Oliver Colfler and David Spraggett. So over to you guys.
Yep. You want me to go, Oliver? Or you
Sure. Yeah.
Yeah. I mean, I think we just need to take this as read. I think both committees have actually discussed this at length, and we're quite comfortable with the statements as they're written.
David, thank you very much. Oliver, anything to add to that?
No, completely agree.
Super. Okay, any questions or observations around this subject from anybody? Okay, I think it's fairly self-explanatory, so thank you both, and we'll press on. So we are now on to the Audit Committee report for the 12th of June, Oliver.
Thanks, Simon. Again, I'll take it as read. I'll just go very briefly through key things. Internal audit, we had significant assurance, which was great. We'll keep chemotherapy pharmacy stock control as part of next year to make sure we keep track of that. Some work on the EPR governance will be needed, which is in line with the EPR kicking off now, so the work will be done on that. The annual reports and accounts were reviewed, and they were signed off and successfully submitted on the 28th of June. So thank you to Kim and the team, who I know worked very late going through to ensure that those all got done. So big shout out and thanks to Kim and the team for that. National cost collection work is on track. We reviewed the contract management process. Great progress on single tender waivers since 2020, so that's really positive to see. And we got the new Healthcare Management Association handbook, and Sarah did a piece of work to look at what we do versus what the handbook says. A few changes that we'll incorporate, and we're going to run a ways of working session a bit later on in the year to ensure that we are as effective as we can be.
Oliver, that's great. Thank you very much.
Thank you.
Any questions and observations for Oliver? Okay, so moving on then to David Spraggett and the Clinical Governance Committee report for the 12th of June.
Yeah, I mean, I'll take the report as read, but would particularly like to raise to the board's attention as something that Fiona's already mentioned. To be honest, there's been quite a significant increase in C. diff cases flagged. Not interesting, not just at this trust, but at many. The Clinical Quality Committee did look at some detail at the work that's being looked at to identify potential causes, if there is any, that we can deal with. And I think I can assure the board that all that needs to be done is being done on that front. And the only other one that is perhaps not in our control is the medication shortages that are starting to become a big issue across nationally. And the issue here is that there are some specific drugs that seem to go completely out of stock, and alternatives have to be found. This actually is quite a cumbersome process sometimes and slows the productivity, if you like, of the organisation as a consequence. But I'm not so sure there's anything that individually as the trust we can do, because these are national issues.
Okay, David, thank you very much. Any questions or observations for David before we move on? Okay, thank you. So that then moves us into the risk management section of the board and the board assurance framework and risk quarterly report. Adam.
Thank you. Yes, this is to note the board assurance framework for this year. So this is the first time this year's board assurance framework has been here, and it includes the risk appetite for each of the trust's objectives, which will be the first time the board have seen that. I think just to note that there are a couple of risks from last year's BAF related to last year's objectives that have transferred to this year, and there are also a number of new risks logged against this year's objectives on the BAF. As you say, something also includes the register of red rated risks in the organisation. I just want to note here that overall, I think we've seen an upward trend in the number of red risks reported across the trust. And I think in part that's reflective of some of the discussions we've already had today on demand and the impact of demand on our services. But I do think we need to subject those red risks to a bit of further scrutiny, and Fiona and I have been talking with services and just QAing those red risks to make sure they really are red risks, to make sure we've got appropriate mitigation in place, and understanding resultant scores following that Q&A process. So we will review that in more detail at our next risk management board in a month or so's time, and obviously we'll bring the updated report back here. I'm happy to take any questions on risk.
Adam, thank you very much indeed. So any questions or observations around risk for Adam? Okay, thank you very much, Adam. So that then moves us on to Harkamel and the health and safety annual report.
Yeah, so I won't go through it in detail, but I would urge all of you to read the full report. There's lots of really interesting information in there, and really good examples of good practice that we should all be really proud of. I just wanted to take the opportunity to thank Joe Beals for pulling all of this together and for persistently keeping us on the straight and narrow when it comes to health and safety. At SWFT, we do have a robust culture of health and safety processes that I would say are well embedded. We had 24 incidents that were reported to the health and safety executive, but none of those were investigated. And we have seen a very, very small decrease in the number of incidents that have been reported, but violence and aggression remains one of our top 5. In terms of our compliance with statutory and mandatory training, we were at 97%. And I've mentioned in the exec summary just around the COVID public inquiry. So that is ongoing, and so far we have responded to one of the modules that has been announced, and in due course we'll respond to the other questionnaires and modules as requested. Overall, I just wanted the board to have assurance that our risk of non-compliance with health and safety legislation is low.
Okay, Harkamel, thank you very much indeed. So any questions or observations for Harkamel? Okay, I think we're staying with you in that case, Harkamel, to talk about the security annual report.
Yeah. This is another really interesting report. So this is our annual report security for security standards. I've said before, because we do bring an interim report back, that we do operate a zero tolerance policy. And I feel like it's really important to reiterate that against the backdrop of what I've just said with the health and safety report. Violence and aggression towards our staff was one of the top 5 reported themes, and hopefully this report will provide some oversight and assurance to the board of the actions that we take in terms of improving the management of security and violence and aggression to protect our staff, our assets and our patients, and make sure that everybody feels comfortable and safe in the environment that they're working with. Overall, our aim is obviously to prevent and deter criminal activity from taking place, but when it does, we have a duty to respond and to investigate and to provide that assurance to our staff that we take these things seriously. So within the report, you'll see how many letters of support that we send to staff, and just more detail around some of the meetings that we carry out, so that people who do raise incidents can be assured that we're taking it seriously and have an update in terms of where the investigation is up to. And I just wanted to kind of finish on the note, it's obvious, but you know, if you think about my report that I presented earlier in terms of how busy the site is and just the unprecedented pressure that our staff are facing, any instance of violence and aggression really does have a serious impact on our staff's ability to carry out their role and treat and care for our patients as effectively as they can. So just to provide the assurance, we absolutely do take these things seriously, and we will continue to investigate and move forward with our aim of eliminating this behaviour.
Thank you, Harkamel, and that is a point well made, isn't it? Because it is worrying to see the continued increase in verbal and physical assault on staff, and understandable sometimes in a febrile environment, but not excusable really. So, Adam, over to you.
Yeah, thank you, Harkwell. It's a really important report, and it's really important, I think, to understand that these incidents are still having and the impact they have on staff. It is particularly disheartening to see continued incidents resulting from race, and I think in the report for the first time, sexually related incidents as well. It's important we know this goes on, but it is disheartening. Most of all, though, I want to thank the work of our security teams and those who support them, because they do a really fantastic job. We've had some incredibly difficult incidents over the last year, and the security teams have done a fantastic job at de-escalating and managing. So I think we need to commend them.
Well said. Thank you, Adam. So shall we move on then to the Senior Information Risk Officer's annual report? Kim.
Thank you, Chair. So I'll take this report as read. So it just sets out really the work over the past year in terms of the way that we manage our information risks as well as our cyber risks. So I just wanted to take this opportunity to thank really the information governance and IT teams provided and supported by Innovate Healthcare Services to ensure really again that we are protected and that we are looking after the information really of the population that we serve. So the report there is for your information.
Kim, thank you very much. Adam.
Thanks, Kim. I could ask this on any of the next 3 reports, I think, but I will ask it here. Clearly, over the last month, we've seen the cyber attack in London on pathology systems, and obviously we've seen similar attacks on NHS systems over the last couple of years. Could you provide us with some assurance on our processes related to security of systems and suppliers?
Yeah, no, that's fine. Thank you. So first of all, just to assure the board, the issue that happens in London it is not something that has affected the Coventry and Warwickshire pathology service here. However, I think it does highlight really the supply chain risk linked to cyber. I suppose with all cyber security, it's a question of when rather than if. So what we need to do is make sure that we have got business continuity plans tried and tested to ensure that if anything happens, we are in a position that we are able to run our services. We are Cyber Essentials Plus accredited as well. So not only our Innovate, but us as an organisation, and that's linked to the next report as well. And so we're doing everything that we possibly can to ensure that our data and information is protected. But if something happens, I think the key thing is about stepping up our business continuity plans. We've just commissioned an external audit report along with George Elliott to actually look at the supply chain and work with our procurement team to ensure that all of our contracts are robustly tested, to ensure that those suppliers who are on our framework can give us assurance around what are they doing around protection of cyber against cyber crime, but also ensure that there are again assurances around the business continuity plans as well. But that would all go through audit committee. So just to give you that assurance.
Kim, thank you very much indeed. So I think staying with you, Kim, we are on to the Data Security and Protection Toolkit Assessment.
I do apologise. Sorry, I forgot to mention as well on this side on the senior risk of the CSIRO report earlier. The report does refer to 3 risks in the report, which I'm afraid I forgot to cross-reference on the front sheet. So I've made a note to myself for next time. All right. So apologies there. All right. Thank you.
Okay, no problem. So
okay. So the next report is really again a report on how we have met the standards. So the requirement is around the Data Security and Protection Toolkit, of which we have 108 evidence requirements. I'm pleased to report that we have exceeded the standards, which is a great work really from the team to be able to evidence that and exceeds standards. So the report there just sets out really what we've done to deliver that.
Okay, thank you, Kim. Any questions or observations for Kim? David?
Yeah, the only question, to some extent, it relates to the previous one. I just wanted some assurance that in the business continuity plans, there is something there about clinical systems, because if cybersecurity takes out our clinical system, it could potentially make the hospital a very dangerous place for a patient. We've got. I'm assuming, I don't know. Can you just assure me that you have got something in place for that?
Yeah, and that's what I was referring to, David. So we have business continuity plans for all of our IT systems. We're working with the emergency planner to ensure that we've got a plan to test those plans, to ensure that we can step up if any situation arises. But obviously, key thing to do is obviously to make sure that our assets, our information assets and systems are protected. And that's a responsibility for us as well as the responsible supplier, but also to actually ensure that we've got business continuity plans set up that we can access, obviously, as well, and that people understand and can mobilise quickly in any event, if any event should actually arise.
So there's some sort of scenario situations where it's been tested.
Yes,
because
we've done
it's
that.
one thing having a plan, it's another thing knowing whether it works.
Yeah, most definitely, yes.
Very good question. Thank you, David. Thank you, Kim. So that moves us then, Kim, on to your last piece around data security and the cyber assessment framework, please.
Yes, so we've had the data security protection toolkit now for a number of years, but we're actually moving to something new. So the National Cyber Security Centre has issued a new cyber assurance framework. So that's basically going to be rolled out for this financial year. So I've got a webinar tomorrow to tell me all about it. So we're in the early stages of telling us what that's about. It's going to mean really a very different framework from the existing standards and the way that we have to evidence. It's going to be much more linking in IG with our with cyber and IT, so much more joined up approach. So we're going to find out a bit more about it, and at a suitable date, I might arrange a workshop really, I think, to take the board through it. But at the minute, we're very much in the early stages of learning what it means for us as an organisation.
Okay, Kim, thank you very much. Any questions for Kim on that subject? Okay, thank you. I mean, I think, Kim, in relation to all three of these last points you made, isn't it? I think the organisation has really stepped up to the plate on these and has really improved its approach to all these issues in recent years, and is really on the front foot in trying to make sure it's in a good place for it. But it really is a very febrile area, isn't it? And important that we do maintain that position and don't allow ourselves to become complacent that we've fixed the issue, and I'm sure we won't in that respect. So that moves us on then to the board committee meetings, committee minutes of the open meetings. And the first one then is Oliver and the audit committee, please. Have you got anything to add to it? And there's
no, I'll just take it as read, Simon. I think I've covered everything before.
Okay, so we've got any questions or observations for Oliver around audit minutes? Okay, thank you very much. And then we move on to David and clinical governance. David.
Similarly, I've got nothing to add to the minutes.
Okay, thank you very much. So any questions for David? Okay, lovely. So any other business? Okay, thank you. And Sarah, I don't think there's any questions from governors or members of the public for us to address at this meeting at the moment.
That's right, Simon. We haven't had any submitted.
Okay, thank you. If there are any members of the public who have a question they'd like to raise, we're happy to take it. Okay, in that case, thank you all very much. So that's the end of the public board meeting. So if we get together for the confidential meeting at 3:15, then that would be great. Okay, thank you all very much.
Thank you.